too. So here's probably the one area that most people are very interested in right now in healthcare in general, and that's the one big beautiful bill. It is the first bill. I'll talk a little bit about this later. That probably historically one of the most impactful since the balance budget act of 1997, and then subsequently the Affordable Care Act. These are probably this is probably very similar to that with some of the provisions and changes. Now, I'm going to talk to you about this in a perspective that might be a little bit different than what you're hearing about. Okay, I'm going to kind of paint a picture for you when you're looking at provisions that are happening. There's a lot of people very nervous about what's going on, depending upon who you're looking, who you're talking to, who you're listening to. Kind of give you some more information to help you form some of the opinions as you work through it. And then we're going to spend some time on the Rural Health Transformation Program. And that's very, very critical to many of you guys here in the room right now. There's a window of opportunity, and really excited about the notice of funding opportunity that just came out that had EMS in there. There was a lot of work that several of us did in the past 6 months to make sure that happened. And so there needs to make sure that we're all at the table. Because what we don't want to do is have the same thing that we have with the emergency triage treatment or transfer EC3 model, where we got something done, but we only had 241 people apply for it. Even though there was other issues with it, COVID came up around the same time. And so I'm hoping we have strong engagement. We are working with several states right now. I'll kind of walk you through some things, okay? Everything that I'm going to be talking to you about is through a nonpartisan lens. So I don't care where you stand, you support the Trump administration or you don't support the Trump administration. I really honestly don't care. It doesn't matter whether I do or not. Ultimately, politics is a chess game. And if you play checkers, you lose, but you need to understand how to play the game. And so we have 3.5 years of this current Trump 47 administration, and it is moving pretty quickly. So I'm going to kind of walk you through what to expect, how we're going to be working through this process, your pivots that need to happen. And so you'll hear, if you listen to any of my webinars that I'm doing, podcasts, things like that, you're going to hear me say a lot. Are you protecting and preserving? Are you adapting and innovating? Okay, because what you decide to do is going to determine the trajectory of where you're going to be. And so I'm going to adapt and innovate that. And so we're in that process of how do we adapt and how do we innovate. Most of you that don't know, I am with Solutions Group Services. We are a technology company, a healthcare technology and services company. Check this out, a lot of great things that we're doing now that AI is coming or what have you. We're fast growing. It's been fun. So I'll just kind of move through that. Kim, will they have these present? Will this be all distributed to them, or do they need to download later?
I don't have it, so
Yeah, I'll make sure that you guys get all these presentations.
yeah, I can send it out, and we're recording it, so
No problem with it. I'll make sure you get all this as well. So let's kind of talk through some of the provisions that happen. I'm liking this more versus the Affordable Care Act. The Affordable Care Act was more about the health insurance side of things. The Balanced Budget Act of 1997 did a major overhaul of healthcare in general and of our EMS system. And so if you pay attention to what actually happened in 1997, it actually created the fee schedule that we have now, this national fee schedule we have now. I find it very interesting that we're now talking about cost again. But remember, if you were around in the 90s in EMS, you were being paid reasonable cost at the time. When the Balanced Budget Act of 1997 happened, we went to the fee schedule as we know it now. Okay. And also, at one time, you could accept Medicare if you wanted to, or you didn't have to. Now you have a mandatory assignment request as well. And then they did a lot of stuff with rural and non-emergency adjusters. These are these adjusters that we keep talking about through the process. I think you're going to see some more change because generally, when I talk in the rural areas that we're talking, it's kind of getting an understanding. There is no amount of money that CMS is going to pay you that is reasonable for what you do in your areas. Okay. Now, to logically think they're going to pay me $25,000 of transport in rural when I'm taking one Medicare recipient every other day, it's probably not a reasonable thought process. So that means you're going to need to be thinking outside the box and how reimbursement is going to happen in the rural and super rural areas. The Rural Health Transformation Fund or the program that they're putting together around that is an indicator for you what you're looking for. So I'm going to talk a little bit about that. You're going to see me, I'm going around talking to many rural people as I can. At the end of this, I have a podcast that I have started, and it's going to have a lot of people coming out from the podcast. You can download it. So if you're on YouTube or any podcast channel, you can start listening. I'm going to have healthcare economists talking to it. I'm going to have people talking to it that's been on MedPack. It's not just from me saying this, you're going to hear from people that are going to talk down to what you can actually understand, okay? Because that's the only way that we're going to change this narrative and expectation that we have in the industry. And let's talk about OVA. And there are three, I'm going to break this down for you because it's really easy. It's a very complicated bill. It's over 800 pages. And I'm only talking to you about the healthcare provisions. There's other stuff in the One Big Beautiful Bill Act that is advantageous to some of your employees. And I'm not getting into any of that. I'm going to just talk about the healthcare provisions because that's what we're most worried about. And that's usually why you need to legislate this through a lot of the land of healthcare product. Okay? You have three major issues, three major areas of this. One is Medicaid enrollment, one is Medicaid financing, and then one is the rural funding. And I'll talk you through some of that. The Medicare enrollment is all this stuff that you're talking about. They want to eliminate individuals that are able-bodied, that they see the access to Medicaid. We still have individuals that are here that are migrants that are not necessarily U.S. citizens. They want to do something around that. Also, you know, there's some issues that happened with the Affordable Care Act, where some politicians believe, and some of the numbers believe that there are people on Medicaid that probably shouldn't be on Medicaid because we're not doing a retro eligibility. It's basically a one-time eligibility once a year. There will be more eligibility requirements around that. So there's a lot, and this is probably the controversial piece of everything that happens. Why is it important to EMS? It doesn't really matter whether you have insurance or not. I'm picking you up. It's not like somebody's having a heart attack and I'm going to ask you, oh, you're not over here legally? Oh, I guess you're just going to have a heart attack. We're not going to do that. The humanity side of us would never. Okay. Now, there might be some people that would do that. Those are the exceptions to our society. But generally speaking, you in this room have a call. You're not in EMS because I'm going to make a ton of money out of you. Okay, I'm in EMS because I wasn't so fantastic. Maybe my parents, generational, whatever it is. And that's the one area that we should focus on. Okay, so when we're having conversations, there's politics that come into it, and then there's policy. I like the policy. I hate the policy. Because that's where good policy, great policy begins to happen. Then you start getting into the ring of the politicians, and you're like thinking, I agree with you, Adam, but we can't do that because if I do this and this happens, and my constituents will vote for it, and now things just break down rapidly. Okay. And so that we've got to start thinking around thinking, have we thought about having an EMS safety? Okay. Maybe there needs to be an EMS safety net funding. So this gives cover to the politicians. It allows them to say, you know what, we understand that the low communities in our areas throughout the United States. It gives them cover. They've created something for the emergency medical services and the safety net. There's the middle they do with the rural hospitals. Now, then you get the back and forth. Well, that's not enough money into the rural hospital fund. They only gave it $50 billion. It's $133 billion over 10 years. Is what it was cost. Or over that 5 years, not 10 years, but over 5 years. We're only giving it a third of that. Here's the issue that we face. And this is where we really have to have real conversations with ourselves, the healthcare community, not just EMS. Is hospitals are on the chopping block. Okay, they're feeders. EMS. We also provide, so people don't like to get into these conversations. Thankfully, I'm a healthcare technology. I really don't care. At this point in time, it's kind of heavy to get older in my career, but let's just talk and be brutally honest with ourselves. Are we making money or not? Okay. Talked about this with the CEOs for a large non-profit hospital system. They're planning on shutting down several of their rural hospitals in some of their communities because this is going to really cause a problem to be able to deliver services because they're going to do their loss of Medicaid. So how that work? They had a board meeting. They have 20 people on their board. They had a board meeting 1 week in Jackson Hole. And they got on 3 of their G-series planes and all the people over to where I'm at, that you're seeing their hospitals. So here's the issue. If we see that, so does the administration. So does the legislators. Okay, there was an article that came out from RAND, which is is a group that actually takes data. They were supposed to be nonpartisan, but they took all of the 990s that were filed by nonprofit hospitals, as well as their hospital cost report, and they looked at it over a span of 10 years to determine what the salary increases were for the executives versus what they were for general line RNs, nurse practitioners, medical doctors that work with them. What was that piece of it? You know what they found? About a 9% increase over the 10 years. Mid-level practitioners and their executives had almost a third increase. Now, this is data that you reported on your 990 and on your hospital cost report. So this is when we're saying, if you have a conversation, is you're going to have to know your data. You're going to see me talk about that as EMS as well. And we've not done that. I don't care if you're a for-profit, nonprofit, governmental, know what your data is, know what's happening in your information, because it will be used against you if you put it in this protect and preserve it. And you don't want to be adaptive and innovate. That maybe our model could be a little bit differently, but we don't like that because we're changing. Okay, let's talk a little bit more about what's going on here. So, CBO always scores a bill. This congressional budget office, once they passed it, there's a lot of discussion around that, and they were going back and forth from May until they actually passed it on July 4th. That the CBO actually scored this at a budget deficit of about $3.4 trillion. Okay, so they would think that this was going to add about $3.4 trillion to the overall national debt. 10 million individuals become uninsured by 2034. Pay attention to that number. CBO scores on a 10-year platform. Okay, so I'm going to walk you through some stuff because there is some mirror monitoring going on here. It also talks about it's going to lower the average gross benchmark premium for those ACA plans by 0.6 by 2034. I'm going to talk a little bit about that. That's very, very impactful to EMS. And it also talks about the $1.1 trillion in cuts in direct spending. This is the $1 trillion that they're talking about cutting spending in the Medicaid program. Okay, this is what's got all the healthcare providers up in arms. Is you're cutting $1 trillion out of the program. And so what does that mean? Technically, when you cut it out of the program, people move uninsured, or people have been using this stopgap funding. What does that actually mean? For you that are interested, I like a lot of the work that Kaiser Family Foundation does. Some people don't, but use who you want to use. Kaiser Family Foundation, Commonwealth, the Heritage Foundation. So depending upon where your politics lies, some people want to always go to Heritage because that's more of a very Republican-leaning foundation. Kaiser Family, in my opinion, is probably more neutral. What we would consider down south, when we used to have Blue Dog Democrats, it's kind of like that. God forbid we don't have those anymore. And then you have more of the Commonwealth Fund, things like that, where they could be considered to be more left-leaning. So figure out where it is. They all kind of align if you look at Heritage, Commonwealth, as well as Kaiser, around where the money is coming from. Okay, so they look at it by ACA expansion, and they're basically saying $326 billion is going to come out of the Medicaid system in the workforce requirements. So over 10 years, we will see, because they're going to basically say able-bodied patients. Generally speaking, guys, there's a lot of exceptions. So for instance, if you're a mother of 25 and you have a child of 8 years old, you're not coming out of Medicaid. Okay, because there's an exception for it. If the mother has a child at the age of 14, you're not considered able-bodied. Okay, there's people on Medicaid right now that are 27 years old. They don't have any known disability. They have Medicaid. They could work. These are the type of people that they're talking about. They believe not. There's a lot of exceptions into it, but they do anticipate over 10 years this is going to save the government $326 billion. Because it's not associated just with the eligibility and enrollment, there's also all these Medicaid financing programs, think your G&T programs, CPE, where people get money from those because of Medicaid lives once they come off. So there's kind of a waterfall kind of approach. Provider taxes is another. Provider taxes should not be conflated with your G&T program. This is not IGT specific or certified public expenditure specific. I'm going to get into that because there has been some misinformation that has gone around the industry about the impact of the limited viewer bills. to your PPE programs. It's more on the eligibility side that's going to impact them, not necessarily the provisions as you saw people were talking about it originally. And that's usually what happens when we get out of the gate too quick with our information. We sometimes have to retract it. And that's why you saw a lot of us didn't know that time at first. We were really trying to understand it. This is my same standpoint. There's a lot of fear mongering still going because all of these projections are 10 years. Now I'm going to walk you through practically those of us that deal in politics a lot, but some of them actually need to stay. So let me tell you where you get the 76% of the reduction of that $1.2 trillion starts in 2030. Okay, so 76% of the cuts that we just talked about starts in 2030. Now, it's really important to know. Now, why is that important to know? Because of this right, I'm going to fast, because of this right here. If you were watching the debate, Congressman Thomas Massie was the only one in the House on the Republican side that voted against the One Big Beautiful Bill. And this is what he said as to the why. He was demonized for this, but I'm going to back into why did he say that. And I'm going to ask you why he said that. Here's what he said. Here's the problem. We're cutting more taxes. We're increasing spending. And to the extent that they say we're cutting spending, that doesn't happen in these first few years. They're saying we'll do that in later years. The problem is the later years never cut. Anybody want to take a guess about why that's so important? Generally speaking, when you have a major bill that passes like this, if the savings aren't realized in the first 2 years, it's what we call spending money. Okay? The money, it just happens in order to get the school. How many remember the sequester? That everybody was upset, 4%. Everybody's gonna receive it. The DA's gonna receive it, the defense department, everybody's gonna receive a 4%. Whatever. Has that ever happened? Guess when they passed it? 2012. It is 2025. And you still don't have this question because you know when they're about to start it again, guess what they do? They tack it on to a bill, another bill, and they just keep tacking it on. So here's what I'm going to tell you. Because when you start looking at a few things through the process, you start doing the math of the politics, not the policy. So people that don't understand the merging of policy to politics, you will get up in arms because you'll start listening to the fear mongering. And so the fear mongering starts, and lobbyists love it because it's like thinking, oh dear God, I need to sign a contract with you for 6 months because you're going to help save me. Or it sure does make great for people like us that go around speaking to make you feel fear. All right? I'm not doing it because you shouldn't feel fear right now. Number one is Louisiana takes 19% of the overall Medicaid cut for 10 years. Who's in Louisiana? Maybe the Speaker of the House. Maybe the chair of Senate Health. Maybe the House Majority Leader are all in Louisiana. Okay. I'm not paying attention to the blue states right now because if you're in the blue states, I'm just sorry for you right now. It is going to be a rough ride for you. But I'm going to talk to you about story branding, hero guide, because there's a lot of things that you guys can do. You just need to partner with somebody else use your mouthpiece. Texas is 8%. Makes sense. So when I start looking at the politics of this, Pennsylvania's at 15%, very strong. Purple state that you'll need. What's coming up in 2028? So let's go back. So look and see this. I'm spending some time on this because I want to kind of paint the picture for you guys on why some people are saying, I don't understand why you're not expressing a little bit more fear. And I'm like, because I understand how politics works. So I understand in 2026, 17 billion is going to come out of the playground. The majority of that 17 billion is coming out of 4 states: California, Massachusetts, Illinois, and Connecticut. Okay, so I'm not too worried about those states if I'm the Republicans. You're already blue, and you ain't gonna vote for me anyway in 2026. It makes sense. So I've got a midterm year election happening here. In 2030, in 2028, guess what's happened? Another presidential election. And when I see states like this on the list, that's going to impact a major population of people going off Medicaid rolls, we start to have a problem. Okay? Now, we do see people jumping the gun a little too quickly. And the CR or the budget, we're about to fund the government. The government has to be funded by next Monday. Okay, so you're hearing a lot of that starting happening. And so you're seeing people take jockeying positions And unfortunately, the Dems have put a proposal together to unwind some of the Medicaid cuts from the one big beautiful bill. Now, if I'm doing that, I'm like, that's not a smart strategy. I would wait until next year. Okay, I would wait until next year to start that. Because the problem is, guess who's gonna receive the majority of the cuts in 2026 and 2027, or 2026, 2027? Those four states. Okay, so they've got to put together policies and procedures. That's why Senator Schumer has been very adamant about that, because guess where Senator Schumer is? In the state of New York. And Hakeem Jeffries, who is the minority, if the House goes to the majority of the Democrats, he is in the state of New York. So he has to answer to his constituents. So some of this is politics beginning to play out. Okay, this is why I hate politics, but you got to know it because it's a chess game. So you got to play the game of what's going to happen through the process. The likelihood that we're going to see something happen, and more than likely it's just another kick the can down the road, is more than likely going to happen with the CR. But what we do have to pay attention to is what are the ACA benefits going to happen, and that is these exchange rates. So when the Affordable Care Act passed, think you've got patients that you're transporting that have Blue Cross Blue Shield of Colorado, but it's an exchange plan. They're at 200% of the federal poverty level, and the government has been subsidizing their out-of-pocket to Blue Cross Blue Shield or their premium dollar. So, for example, $250 a month is what they have to pay their premium, but the government has been paying and subsidizing that for them. As of the end of this year, those all go away. Why is 930 very important? Because plans have to start notifying their enrollees in October of any plan changes for January 1st. Okay. And so if that does not happen, enrollees will start to get letters that currently we have your $250 been subsidized. There's been an increase now to $270. In order for you to continue with this plan, you're going to have to start paying $270 a month starting in January. Well, every state has expansion populations. Every state. Okay. Now, some states took over the control of it. Some states did not. The states took the control over it. But every state does, regardless if you're red or blue. They're anticipating this to be an additional 12 million people to come off the rolls of having insurance. Okay. Pretty huge number. The concentration of a lot of enrollees are happening in Florida, Texas, California, New York. But what are Florida and Texas? They're red states. And they're strong Republican states. What do you think is going to happen if all of a sudden 3 million people in their area no longer, they make $75,000 a year, but they're getting a subsidy payment to help them pay their premium for their Blue Cross Blue Shield or their Aetna or their Cigna? Okay, this is why we're focusing on certain states. I love y'all in Colorado and focusing on it. Because y'all probably not the voice that we want at the table right now, but you can influence the voices from another state. That's what I'm going to talk about. As I'm kind of going through this process because that is impactful to EMS and but if they don't do a subsidy, because I can't control that, but what I can control is to say, we probably should start working with our legislators on maybe if you don't do that, you need to understand the impact it's going to be in the 911 communities. Maybe you need to have an EMS stabilization fund. So can you appropriate money into a fund that then can be administered by the states and then can actually kind of work very similar to this rural health transformation program, but it's more of an EMS side of it. Okay. A lot of it was sometimes we have done this. This is not new to us. Remember the trauma funds? So we did the trauma funds. Sometimes you guys have advocated to the hospitals. The hospitals took most of the money and maybe gave you some dollars and change, maybe 10% of it. But it's not a new concept. But it's a new argument now as we work through this because we don't know what the politics are going to do. If anybody tells you that they're going to predict how much the administration had influence on this Congress, I wouldn't believe a word anybody's telling you. Because everything that everybody ever said is going to happen, it is absolutely happening. And so there's a presentation I did yesterday or the day before in Texas that really kind of walks you through. I'm not doing that here today for you, but kind of walks you through kind of a timeline to try to understand the executive orders. As of September 2021, President Trump 47 has issued 205 executive orders. That is more executive orders than any modern president in recent time. And the executive orders paint a picture for us. So if I'm in healthcare, he's telling you everything he's gonna do. How many went up in arms about the SAC advisory committee being disbanded? Don't raise your hand if you were one of them. But the industry kind of went into a knee-jerk reaction like we always do. And I remember one of my colleagues got on there and I actually picked up the phone and called him and said, take that down. Take it off your social media. It's gonna come haunt you. And not because you don't understand the reason what just happened here. We're not paying attention. He had an executive order that came out that he wanted all what they call woke ideology. So if you were for diversity, equity and inclusion, if you had anything like that in anything that you did, then they didn't want you on committees. Well, there were 4 people on that NIMSAC committee. One had actually written something about climate change, something like that. So it just took time to get to us. They just disbanded the committee and they're gonna get people on there that don't have that stuff. So I was at dinner. This is so anecdotal, but I'm gonna tell you anyway, so that you understand how this works. 3 weeks ago, I'm sitting and having dinner with an AI company. Because of course I'm a healthcare technology company. We're kind of looking, I'm kind of crawling, walking right into it because it's just, I think it's another hype word that we all like to talk about. But there are some really actual wonderful things that are going on in there. One is, some of us have actually put together, remember, some of you guys maybe got like Google, things like that, that says, give me the keywords, and it'll kind of give you keywords about your, tell you if there's an article or something like that. Well, AI is on steroids with that now. So what I found out was this firm had a contract with the administration that can actually do key buzzwords on if you ask to have a meeting with them, they're running you through the algorithm and they get and understand where you are with something. So it kind of determines whether you get a meeting or not. Pretty smart, isn't it? I'm thinking, I'm using that too, to hire somebody. Like and scrub and see if they made any controversial posts lately. What have they done? Like think about that when we do our own research. I mean, we were researching, scrubbing people's social, like thinking, are they what they portray to be? There's some people I haven't hired because I'm like, oh, you're not looking what they post on social media. It's a no for me. Does that make sense? But they're now using that, and that's not just them. There's a ton of companies doing that. But it's those type of things that are saying everything that you say now, these are the things that AI has come into place, whether we like it or not, has now opened up. So every word you put out there, everything that you say now, everything that you do, just know, stand on it, stand on the principle. Okay, we said one day or whatever. But if you want to be at the table, that might put you at the table. You might have to talk to someone else to be at the table. Does that make sense? So those are the type of vetting things that you need to talk about, but that is actually being done right now. So if you didn't support the One Big Beautiful Bill, if you're out there making statements negatively about the One Big Beautiful Bill, and you want to have a meeting with ODP in the White House and the Office of Domestic Policy, more than likely you probably aren't going to get it. It'll just be slow walked. You know what I'm saying? But if you are very supportive, you're better to not say anything than to say something. Does that make sense? And so that is where we have to be wise as an industry, get a little smarter on how we're doing things, because this is the AI revolution that is coming, whether we like it or not. Okay. All right. You're going to see me say this a lot. Protect and preserve. So you got to think about it. This is, you don't have to answer today. And I'm actually going to take you guys through, they asked me at my last session, I'm just going to take you through kind of a leadership exercise about leading from support, leading from a position of support. How do we do that? Because I directly think that our impacts at the healthcare community has been how we get. All right. We've not gotten some things that we needed because of that piece of it. And I'm going to take you on the journey that I've been on. What we've done, some things literally changed the narrative over the last 6 months. And I've literally equate that to how we're so successful getting EMS as a scoring point in this notice of funding opportunity for the Rural Health Transformation Program. And so it's going to be that piece of it as well. Here's another thing, and I know a lot of you guys do that here in our facility conference. That's another piece of the One Big Beautiful Bill that's in here, because some people may not understand that it's here. Is around the modifying of cost sharing requirements. Okay, so starting in 2028. Now, whether they get that far or not, we'll see. There is going to be a shift of modifying cost sharing requirements for Medicaid recipients. Okay, so basically, if you're at poverty level, not a 100% or over a federal poverty level, they can limit you about $35. All right, but there's some exclusions: emergency services, which gives me a little pause of concern, because technically, emergency services right now, as defined, is kind of tied to a hospital. So if you're a hospital type thing, this is the issue we're running into with Medicare Advantage. And where it's kind of a slippery slope, and this is why we need more of a direction from this administration to resolve that slippery slope. But these are the people that can't be, that are excluded from it as well. So technically, we're gonna work on this and just to make sure that 911 technically would not be involved in this. But theoretically, if you do inter-facility transfers, like ALS non-emergencies, hospital to hospital, that might be a non-emergency, things like that. Theoretically, they could subject these individuals to a $35 cost limit. Well, if they're at 100% federal poverty level, and many of you guys might have contracts instead that says we don't bill patients, we're a government entity, we just take insurance only practices, that's very common around here. You just took another $35 in that insurance. Okay, so these are areas to pay very close attention to because there are some modifying cost requirements. Now, this gives the ability to the states to implement this. They don't have to. If you're in a blue state, seriously now, you're gonna do. Okay. If you're in some of my neighboring southern states like Alabama, I can see people. You know what I'm saying? I could see, depending upon where your trajectory is and how you view things through your lens of politics, you're going to see that. So I don't technically see that being an issue personally. If I was looking at it from my political lens in states like your state, California, New York, Illinois, I see this probably more problematic for those ambulance agencies that are in some of these red states. And this is a really good one. If you don't know, my colleague Kim Godden and I, we did a podcast. I know I've talked a lot about that. If you've not signed up, I would strongly suggest you do. You get actually one really around the importance of advocacy in healthcare, very specifically from the non-emergency side, the inter-facility side. It's a fantastic podcast to listen to. Kind of talks you through how successful they've been on a few initiatives in Illinois, as well as Indiana. Reflective of emergent or inter-facility transfer work. So it's great stuff that they're doing at the state that I think you probably should pay attention to, start beginning to model, think about how to model that as well. Now let me talk about Medicaid provider assessments. What time am I supposed to stop, Shirley? 9:45. Let me stop here. Y'all okay? Any questions? A lot of information with you at 8:30 in the morning. It was just amazing. Let's talk about Medicaid provider assessments and GMT programs. Colorado has a GMT program, right?
Yes.
I know you don't have a provider assessment program, but you do have a GMT program. So let's kind of talk through what does this mean? What did the One Big Beautiful Bill Act demonstrate? And literally, if you're in the GMT cost reporting side, there are things you should be very worried about. But it's not because of the One Big the One Beautiful Bill where I worry about that because I'm going to lose people off my Medicaid rolls and that's going to impact my payment. But there's a lot of other stuff that you guys should be worrying about that we'll kind of talk through. That initiative has already been down the road for the last few years, and we're expecting the OIG report to come out here any day now. That's going to really impact some of these GMT programs. So state-directed payments. What are state-directed payments? State-directed payments, think Medicaid managed care. It's the easiest way to say it. Okay, so state-directed payments, generally when a lot of these programs come into play, states direct and have been telling managed care organizations to pass this on to the ambulance provider or to the hospital or to the physician. A lot of really big, a lot of these programs have been really big in the hospital arena and the physician arena. It just says if you have a program in place at the signing of the law, which was July the 4th, they grandfathered you in. Okay, so the provisions of this, you were grandfathered in. What people knew specifically, like hospitals, the reason why they're up in arms is generally these programs have to be redone. Sometimes every year, sometimes every other year, sometimes every 3 years. Okay, the minimum every 3 years. So generally, even if you're grandfathered in, you're going to have to go back to the table, draw that submitted approval. So that was some of the concern, the aims that they had as well. Starting in 2028, remember those dates that I gave you? Remember how we said that starting in 2030, 76% of the time. Starting effective 1/1 of 2028, they started to do a 10% annual reduction in the current program rate. And when we talk about program rate, it's that average commercial rate people were getting paid. So Medicare pays, has a rate. And then there was, I don't call it a scheme because it was legal to do, but you could basically take what my top 3 or top 5 paying me, and they're paying me $450 of Medicare. Then the difference between the 100 to the $450, you could get that's like kind of a bonus Medicaid pay that comes back to you. They wanted to start reducing that and they would start doing it over time until they came back to the normal rate. Okay, so if you were an expansion state, they basically said you could go to 100% of Medicare. For the 11 states that didn't expand Medicaid, they said you could go to 110 of Medicare. Okay. And that's where all the energy has come around this. They really wanted to start happening on January the 1st of 2026. This is where I'm saying 2028. There's going to be a presidential election coming up. Hospitals are large employers in a lot of states as well. So you'll see that begin to put a burden. You're going to start seeing that as well. They're going to have to address this because it's going to become a big political hot potato. They'll have to do something to address it. The problem they have going for them is the firm that this administration is really listening to. Remember when people were talking about during the election, when Harris and Trump they kept talking about Project 2025. Remember that? Remember Project 2025? Yeah. That was done by the Paragon Institute. And literally, if you will pay attention to, and if you will take, I've taken the healthcare provisions from the Project 2025, and I begin to check off what they're actually implementing. A lot of the provisions that you saw in One Big Beautiful Bill had a lot of the provisions in them. Okay. There's new things that are beginning to come out as well around the GMT programs, the IGTs. Remember that there was a focused article that it went kind of viral in the EMS industry about California's GMT program. That was all done by Brian Blaze, who's been the influencer from the Paragon Institute that happens around here. So there's a lot of, they have a lot of influence in some of the policies that are currently being done by the administration. So pay attention to that, kind of gives you a window. Usually what I tell people is it lets me know where the landmines. Okay. If I know what the landmines are, I'm going to start skirting around. Okay. When I don't know where they are, I might step explode. I'm in trouble. So that's why you do reconnaissance. That's why you do research. Just understand where doesn't mean I have to agree with it. It just means I just need to know where my landmines are. I got to play the game because this is going to be 3.5 years from now. And I can protect and preserve. I can just get loud about it or whatever. But is it changing your situation? Okay, if you're an advocate for the patient, which is what we all are, then I should be advocating from the lens of the patient. And many times we forget about that as we work through the process. So this is kind of a little bit about state directed. Provider taxes, that is something, generally speaking now, you're pretty capped. And I don't see that going away even after this. Okay, so generally speaking, you're going to be capped at wherever you were at the signing of the One Big Beautiful Bill. So if you had a provider assessment in a program, whether you're a hospital, a physician, an ambulance program, and it's 3.5%, that's where you're stuck. Okay. And then starting in 2027, they're going to start reducing what you can do because you have up to 6% that you have. So if you're in a state that has 6%, like for instance, we were in Louisiana, starting in fiscal year 2028 or in 10/1, they will start to reduce it by 0.5% every year until you get to that 3.5%. So for instance, in Louisiana, the EMS industry will be very impacted by these programs as well. Not just the loss of coverage, but also the loss of the reduction in the cap as well. Okay. And I'm just naming EMS, but this is a big deal for hospital and physician. Right? Here is the one thing that I want you to pay attention to. This is not in the One Big Beautiful Bill. Okay, this is the biggest impact that's going to be to the GMT programs. And this is the opposite sector. We're expecting this audit of these supplemental payment programs that they started in July 2023 to come out any day. Okay, they are issuing it in 2025. We've gotten reconnaissance that they're in the process of getting it done, getting it through approval processes. So we expect that to come out any day now. What did they find? What did it look like? We do know there was a lot of impermissible costs that were being used by providers as well. That did come out. That's why we saw a letter that was in all of the states directing them to make sure that they have an audit tool in process for that. You see a lot of people scrambling through the process of what that is. Here's my standpoint on that. Most people have seen. Pigs get fat, hogs get slaughtered. And just because you got away with it, didn't mean it was right. I hear that all the time. I see that all the time when I do. Well, they pay for it. Well, of course, you can get a hundred percent or see one of your transports paid. Just depends on how I feel it. I need every single one paid. Doesn't mean it's right. Doesn't mean it's permissible. And oftentimes what we did is we didn't have audit play because we trusted the consultant. That's a little controversial, and I get it, and I'm not afraid of controversy because I'm a consultant. You can trust the verify to make sure if it seems off to me, like why would I do that? That seems kind of off that I'm allowed to put all my fire costs into, and they're not all driving to the patient. Oh, but you know what? You could probably here's the argument that you could use: pigs and hogs. And unfortunately, we have some of that going on throughout the industry. And that is the biggest impact that's going to be to these GMT programs. And this is what happens when you get the wrong device. And so, generally speaking, most of the stuff is not a conspiracy. It's just a follow the money gig. It's literally just follow the money. And oftentimes we get into the scenario that we need money. So we rationalize in our mind, and some of these GMT programs, unfortunately, suspect does that. And if I had anybody under contract that got me into this problem, they would not be in contract anymore. That would be my advice. Okay. All right, so let's talk about rural health, because this is where, and I want you to stop me as we work through this, because this is something, an area, and I will tell you, I'm gonna have a direct conversation, guys, because you have a narrow window if you want to be involved. So that the applications are due in November, and they will make the awards, and they are hell bent on making the award by the end of the year. Hell bent on it. And they have to come through the states. All right, so the notice of funding opportunity, the state's government, they all have to sign off by your governor. And so it's usually going to be, each state has the ability to direct who's going to be their chair. I don't know if, do you guys know who that is here? Is it your Medicaid director? Is it your, does anybody know yet?
And it's Nancy with Hickok.
Who is it?
Nancy with Hickok, I believe.
Nancy.
with Hickok.
Okay, so it's Nancy, so you guys do know who's leading it.
Yes.
Okay, are you guys at the table?
We're trying
You're not there yet, so we're talking about.
on paper.
So you're there on paper. So here's probably what will happen, and we're gonna just kind of talk through that. So, because it's moving pretty rapidly, and so if you're not there in the conversation, but you're on paper and they're just kind of stringing you along, that means you're gonna be anecdotal, and they're gonna just try to throw something in there to make it look like they're helping EMS so they get a score. And we'll need to make sure that that is noted. My biggest concern to this is they're gonna pay you for an ambulance response, no transport, and that's gonna be their way of including EMS and helping the rural areas. That's a horrible way to do it. There are some that we have that we're really trying to work on. I'll talk a little bit about, so we're trying to lead. This is an area where you need to understand the hero, the guide. So you need a state, you need to be coordinating with a state that is more in a Republican perspective. So we have focused on South Carolina right now. They've already got their program together. It's a pretty fantastic program. It has already been signed off on, and it's now at CMS. So we're going to try to use that as kind of a template model. We have an overview piece of it, Ohio, Indiana, Oklahoma, really, really involved. Others are involved in it as well, but it's just different areas that they're involved in. I was with my Texas colleagues as well. They're just getting involved. And remember, you want to be talking to the state, not to another association like the Rural Health Association. You're trying to whatever. Remember, they get all the money coming in. Okay, they really don't want you helping them out. I know what they say. They don't. They're very adamant against. They're very concerned that some of these innovative pieces are going to take away from that. So let's talk about what it does. These are the 5 key measurements that they're using in this rural health transformation program. They're looking at making rural America healthy again, sustainable access, workforce development, innovative care, and tech innovation. Okay, we're number 4, and you're also number 3 and number 2. So you're 2, 3, and 4. You can help with making a rural America healthy again. When you go out there and you pick up a 911, what's to stop you from doing this SDOH requirements to get that information over to Medicare, Medicaid, and commercial insurance? And making them pay by creating a model. And they pay you $20. extra to your reimbursement to do that. These are the things you gotta start thinking outside of the box on how do we get the information to them? They need that information. Okay, but too often what happens is the hospitals, through all their E-rate grants that came out, all these high-tech grants, none of that went to us. The hospitals got all the money. And we just give it away for free. And they still aren't giving you the money. Epic still locks the information down. Oracle is still locking the information down under the guise, well, the hospital has to release me to be able to give you the information. Technically, the government paid them for the information. So I don't get the whole issue going on unless it's politics, which we know that's what it is. Just follow the money. That's usually where the issue resides. So you actually feel every single one of this. Tech innovation, or you could look at it, and this is where your nurse triage comes in. This is where hospitals like systems in Denver can provide resources to the rural communities. So you don't necessarily have to be just an ambulance provider in a rural community. Is there a way to get these individuals out? How can we do that? How can we get the high utilizers or low acuities out of the system? Is there a way to coordinate it? Can we work with our telehealth groups? Somebody was telling me the other that home health is out of their area. This is an area where you can live off with that, and there is funding to it. Now, how that looks and how you get paid is what you coordinate with your state. It could be something that they give you a monthly lump sum subsidy to pay for. Some of it could be that it is part of a fee-for-service solution. I'm saying stay away from that, but ultimately states have the ability to design the way they want it designed with different subcontractors, whatever. Okay, and as you know, whenever you're talking about the money and people are screaming in the rural space that they went from 133 billion to 50 billion, keeping what's controlling. Anybody want to guess? Come on, sir, wrong answer. No problem with that. The hospitals. Okay. So they're going to want to control the money. I did a fantastic podcast that you need to pay attention to. I think I put it on here too. But I went, the young lady, she's a healthcare economist now. She actually worked for Ways and Means. She worked for CMS for several years, went for Ways and Means. She's now a healthcare economist. She's got her doctorate, works for Marquette University up in Wisconsin. But she actually was very integral in our extended that we got for 5 years with the data collection. So she worked in Ways and Means at the time. Her name is Dr. Lisa Graybear. And so I interviewed her. We kind of talked about Medicare because her dissertation was on Medicare replacement programs and Medicare Advantage and what our issues were related to Medicare Advantage. And kind of what she talked about through that process. But we started talking about the Rural Health Transformation Program. And here, because her expertise is on the hospital side. She does everything and she get really granular into the hospital later. So she gave me a few aha moments. And one of them was there's only one healthcare provider type that has 53 classes of service to get paid different reimbursement rates. And they've been doing it for 35 years in the hospitals. No other healthcare sector has that many different ways of getting paid. Okay. Now, and they kept saying, well, if you pay us this way, then we can solve this problem. So they created a class of services to let's demonstrate that. And so now the general sentiment with the healthcare economists, CMS is, we're done. That's just disruptive. If you haven't seen anything about this administration, they have no problem with blowing stuff up and restarting it. And they're demonstrating that to you. Now, how can we take advantage of that? But I can't go out there and say that to my hospitals because I'm in EMS. And then it's like, well, they're going to do this. So you get somebody else to say it for you. And so if you go to it was probably an hour-long podcast, but if you go to the last 15 minutes of it, she does it and sets it up directly for you. And she says, don't give them $1 of the $1 billion. She said, we need to start giving the money to other healthcare sectors. We've tried with them for 35 years and they've not been able to do anything that they said they were going to be able to do to protect access in the rural areas. It needs to go to telehealth companies. It needs to go to FQHCs. It needs to go to EMS. And so you have somebody else beginning to tell your story. Okay. And then you have the data companies beginning to tell the story. The outcome data, we have outcome data. If it had not been for ESO 12 years ago, beginning to work and get a longitudinal record. They are the only ones in the industry, and I don't care what anybody else says. Others are coming, which I'm happy that they did, but they had the foresight 12 years ago to start connecting the data, and now they've got outcome data to about 41% of all emergency records. That's a really good data set now. So we can now tie data to the actual longitudinal size of the hospital to the field. And what we're beginning to understand, and I'm releasing another podcast that actually comes out this afternoon with Dr. Beck, the CEO of that kind of talk with the outcome, what the outcome actually says. Take stroke, for instance. We misdiagnose stroke patients when they call 911 53% of the time. 53% of the time. Because you know why? The person fell and they fractured their hip. And we treated the fracture. We get there, the hospital record actually diagnosed the patient. They actually have a stroke, which caused it. So then we should be taking that data to go back and train. How do we do it? Because to us, and people are like, maybe that's a small percentage or whatever. You're exactly right. It's a low utilization, but it's a high impact in cost and dollar to Medicaid, to Medicare, and to everyone else. So what you do is you couple it with this, and then how do we also take out the high utilizers in our system that have a low acuity before they even call 911? How do we pay for that? What does that look like? These nurse navigation things that people talk about. I'm not going to opine on which one's the best one or whatever, but it's like these are the things that we should be thinking about. Workforce development. This is what they're doing some work right now in the state of Texas on. They've got the academic centers have to get more individuals that are going through and getting their doctorate degrees or whatever, or doing like a 9-month stint into the rural areas as part of their programs. And it's like, you know what, you can offer them a bonus payment with this to keep them in the rural areas for 2 years that helps to subsidize and pay for their college. That's what they're doing with the MD. That's restricted just from medical. How do we keep workforce development into those rural communities? These are the things that we should be thinking about, not just, oh, I'm going to get paid for ambulance response and transfer, or oh, they need to pay me another $2,500 for a transfer because it takes one of my services, one of my units out of service for 4 hours in rural Colorado. Does that make sense? You need to start thinking outside, like what else can happen? How can I do this? This is what the grant was meant for. Outside of the box stuff. Now you got to get the table. Because your states are submitting it now. Okay, that's what's critical, that's what's key. All right. Here is kind of the way that it's going. They've already released it. If you haven't seen it, the application did release 2 days ago. And it's fabulous. Most of you have seen it. Everybody was really excited about giving their very strategic. This is why we had data companies lead this initiative. And the clinician was the people like this. So we started getting, I don't even advocacy for 20 years. And it's only been inundated. Because guess what? There's some places you don't need to be at the table. You need to have other people at the table. So the people that have the outcome data need to be at the table. That's happening. So the people that are the clinicians, the physicians, be very physician led in that piece of it as well. And those that understand reimbursement can come out on that piece as well. So they're asking how do we get at the table of that? That's when the people like you guys, you gotta know your politics. Who knows what? You guys have an aim of who's leading it. That's who you've got to get at. That's where you have to go. And you need to be working on it now. Who is the person that has that relationship? And we have to be able to say, I'm okay with it not being me. I'm okay with it. I'm just picking on you, Kim. Is it Kim? Kim's got the relationship. Let's work together. What do we want this to look like? Get at the table and start working on it. Okay. Here is something that here, if you scan this, it kind of gives you, and I'm going to tell you, there is a piece that has come together that talks about a smarter state-led path forward. And there is a group of adults that worked on this for the last probably, and it's why we were successful getting this piece out. And we're sharing this with you. This is not anything new. This is a good one-pager that we were able to get out to everyone. And we're beginning to send it out now, saying if you're getting down, you're having conversations with your states, make it very coordinated, the same message. So if your state governor reaches out to the governor of South Carolina, probably won't happen, but I'm just giving that as an example. But it will be the same general theme. Like, yeah, this is what we're working on. Does that make sense? So you start working through the process. This is just simply a guide to provide you with what does this look like? This is not anything new. You guys have been talking about this for years already. It is just now putting it into a visual that tells a story. And we're telling the story from the data companies and from the clinicians. Okay, you want the physicians at the table. Dr. Oz and Secretary Kennedy sent out the advisory committee that they're looking at, and you want to see that, there was a advisory committee they're putting together to advise CMS and HHS on how to make America healthy again, how to create different initiatives that are innovative, very similar to what we saw here, that will be sitting and then advising. We would like EMS to be on. So that the applications closed on Monday, and we have a few people that we really took a very, very concerted effort on one individual to make that happen. Okay, that can lead it from a clinician perspective and from a data perspective that has the influence to make things and to make sure EMS's voice is heard. As well. Like for instance, it can't be people like me. I don't have like you gotta have a technology side, you gotta understand the data side, you gotta understand the clinician side. So who are they, what do they do? And that's an area to look at as well. So those are some of the things. I'll kind of stop there because we've been talking a lot, and I'm going to wrap up here with some things. I think the one thing to note, y'all need to identify as an industry who's the one person that's working with the state of Colorado. Because literally, you have about 6 weeks. You literally probably have 2 weeks because they got to develop the program, they got to develop the NOFO application, they got to develop all the information to get it submitted and over. So you really have 2 or 3 weeks.
I was gonna say, I know we have representation, I don't know who it is, but I know we have representation from NAEMT, or not NAEMT, sorry, COEMS. There is somebody sitting there on that group from there. And we did a presentation, what was it, 2 weeks ago? Before the HCCUP Medical Rule Board, which is a single entity making the decision. And we actually tied it to the first 3 years the ambulance sustainability task force work, which aligns with those 5 things that you put on there. The recommendations out of the task force perfectly align with those.
Perfect. And that's what I would be using and then having funded. So that's going to be your area of guiding your state on how to fund those initiatives. So they want to know how we fund it. Is that going to be a bonus payment? Is that going to be an extra coverage of something? Good. All right. It's interesting to see what the states are going to put together by the end of the year and we work through. To me, this is kind of the crawl, walk, run component for our industry. And to me, for this to happen, we have another bite at the apple because now is the time to do this. Remember, the Rural Stabilization Fund is just one thing. The Centers for Medicare and Medicaid Innovation can open up a whole other thing. Our thought process is that we're working on right now is if states get their stuff passed with EMS in them, we then, because remember, this only covers the Medicaid portion. Okay, it only covers the portion of those lives covered. So you still have Medicare, Medicare Advantage I have to pay attention to, dual eligibles, things like how do we make that happen? What we then want to happen is the Centers for Medicare and Medicaid Innovation to automatically adopt the mutual innovation model. Okay, so if you have the states that have agreed to these general premises, it automatically is adopted into a CMMI model. Now, states have a lot more flexibility than feds do because there are some limitations regarding regulation. But there are some things that in the previous administration, we were working under ET3, under Trump, and then into Biden, that the Office of General Counsel didn't feel comfortable in the gray area. As we know, this administration, they are totally comfortable operating, challenging it at the Supreme Court. And I just can't imagine that if they tell the industry, sure, we're going to allow you to get paid for it, we're going to have the industry challenge the rule. Does that make sense? If they do that. So that's kind of another context that we believe the Office of General Counsel won't be so conservative in their interpretation of things that we're able to do in the Medicare Advantage program in that demonstration model. So that's kind of another thought that we'll continue to work on as soon as these are awarded, that into next year, it's going to be a really concerted effort to get the Medicare Advantage process into this. So now you've got a full gamut, and then all you have to do is work on the health plan. But we know if you could get Medicare, Medicaid, dual eligible, all that, the plan will just, they'll roll down for free. Okay, so here's some of the things that I would just suggest that you begin to do now, if you've not already started doing. You're hearing us talk about this all the time, but redundancy is what I really believe. You should keep doing it. You should really know your data. You need to know your data as a state. You need to know it of your own internal organization, how it marries up to your states. Now, I've been presenting to you guys for a long time. You guys have a lot of data here that you can look at how many Medicare Advantage in my area. So if I'm in an area, if I want a certain Medicare Advantage program, they may not listen to you because they don't have enough lives to make it even worth their time. So I might have to say, you know what, I need to work with Nick because Nick has more lives for Humana Medicare there, and so I can let him be for it. Does that make sense? And bring it home for all of us. This is what we have to do differently. This is where we have to do, but you have to know your data to do that. Me, but just people start pulling and say, well, that makes up 8% of my volume. But to the payer, they're like, that makes up 0.5% of my beneficiaries in your area. So they're not really incentivized to have a conversation with you. But they might be incentivized if it makes that 27% of their beneficiaries in Nick's area. They don't have a conversation that Nick has to lead, not you. And that sometimes it's hard for us as an industry to advocate and work through that. But literally, we've got to start that collective work through the process. Okay, but know your data. If you need outcome data, I know there's two main companies that are really beginning to look at this now. I know ESO already has that. I understand ImageTrend has got some outcome data coming as well. I think coupled between those two is going to be pretty beneficial for the outcome data to the longitudinal record. Remember, it's outcome data based on a longitudinal, not your own data. Okay, not data that you collect, but how is that tied to the hospital? Okay. So number two is I'm going to suggest that we reflect as a EMS industry. Healthcare generally needs to reflect, and we're not. Some people are digging in, trying to protect and preserve. Okay, those that are doing that are being looked at that you're not innovative and adaptive, specifically at the administration level and the executive level. So it might make good sounding bites for you, but you're going to have to run all your issues through Congress. Because the moment this administration feels that you are not open to change and adapting and innovating, you draw a line in the sand, then everything that you're going to have to do is going to be on the congressional side of it to jam that through. And so you'll need to understand your politics. Right? Transparency is a big deal. And hey, I'm going to talk a little bit about AI this afternoon on how to start dabbling into it. Some of the misconceptions out there, some people are AI being used with medical records, things like that. I'll kind of talk a little bit about that for you. But transparency is a big deal. Okay, people don't forget about that. That was another one of the executive orders that Trump issued. It was one of his first executive orders that he initiated in February of this year. But remember, the healthcare transparency for payers and providers actually was an initiative that started in 2019 under his first tenure as president under Trump 45. So this is not anything new, but just know they are going to be putting this on steroids. There's a presentation that I like to give. I mean, I did this a few days ago, but when you looked at the inauguration of Donald Trump, we saw behind him literally the top 5 tech CEOs. Okay, now AP's news article or news headline said, you know, Trump invites the top billionaire tech CEOs into his inauguration. I probably would have said, because we focused on the word billionaires, they are very, very wealthy. We have a lot of individuals here that are extremely wealthy. Some people would call it an oligarchy regime or whatever. But here's what I'm saying that people are missing. Take billionaire out, exit out. He had the top 5 tech CEOs around. What was immediately implemented? Elon Musk, taking out the Department of Government Efficiencies, DOGE, which was called something else because we the establishment of the Affordable Care Act. But they started to use AI algorithms. They didn't allow people to begin to implement AI to get the information. That's all we do. Okay. Now, data and how we collect have all different contexts. And we don't look at it in the context of it. We make different decisions because it's very interesting. A lot of people they let go, they're now starting to hire back. You know what I'm saying? So, I mean, CMS is hiring back 434 people, 1,100 were let go. You know, some of the other Department of Defense are hiring back people. Now, it's being like a lot of other news headlines are capturing over here because we're distracted watching this, but all this is happening here again. Okay, it just tells you data tells you a different thing. Okay, so know your data, transparency is coming, AI is being used, and this is why we have, somebody was talking to me about prior authorizations earlier. There's a WISER initiative that is happening from the Centers for Medicare and Medicaid Innovation, how to use AI to help streamline the administrative burden around prior auths. They're not getting rid of prior authorizations. They believe that there are AI tools and And that's why they created a demonstration program to get the AI companies to come to them and say, show us and demonstrate for us how you can make this administratively simple for the providers. Because you understand the value of prior authorization of loan. And it's called a wiser initiative. Right? So anybody that's telling you prior authorizations are going, they're not. They're trying to make it more administratively less burdensome to providers. The second thing that they're working on, and this is new, how many have heard about the chili cook-off that CMS is doing around fraud, waste, and abuse of AI companies? Somebody saw that? Okay, so there's a whole thought concept that they had because this administration actually put together a whole division around fraud, waste, and abuse. Okay. So they believe there's about $1 billion in fraud, waste, and abuse that happens every year. Now, what makes for sexy headlines, folks? When they take somebody, they find $10 billion and they put it in jail because they were sending bills on fictitious patients. You know that makes up less than 10% of the overall fraud, waste, and abuse in the industry, healthcare industry. Okay, I liken it to like when we used to get all this notoriety about the dialysis transports, and we used to go back and say that essentially only makes up a small, tiny percentage, but the whole industry looks bad because of the dialysis piece of it. Okay, fraud's not there, but you know what is? Waste. Okay, abuse is a little harder to, it's almost intentional as well. It's kind of, if you're looking at it in 3 different tiers, fraud's here, that's an intent, willful intent to defraud, you know, I'm billing for transport that never existed, that's fraud. Abuse would be, you know what, I'm gonna go over there like this. Okay? But I have to knowingly do it, so they gotta be able to prove that I knowingly knew not to do it, made specific instructions, not really fraud. The patient really needed to go by something that makes them to need to buy chicken or buy animals. Maybe they need to buy chicken. Waste is I'm just coding things incorrectly. I have a lot of waste in the system from my cost reports where I'm getting uncompensated care, or maybe I'm smudging the edges a little bit to put in costs that maybe not directly care related. That's the stuff they're trying to get at. And that's where they want to use AI. So this chili cook-off, they're basically saying, in order for you to get a government contract, AI, individual, let's say Google, you need to demonstrate to us how you can find the fraud, waste, and abuse. And we are going to then run and analyze it to make sure we agree with your assessment. Does that make sense? Those that can do that, we are going to sign government contracts, and you'll start working with our RACs and others to find waste and abuse. Okay, so what does that mean? That means know your name, folks. Trust but verify. A lot of times what you do is to say, in EMS, we would be like, you know, we're so small, they're not going to come after us. So I had my general counsel, and I've got a whole, I'm actually into a series of webinar on this. But I have her actually pull every single OIG ruling that was made on EMS providers. And we started going through it, like, holy shit. They just got a small little volunteer West Virginia fire department, and they made a payback $33,000 for this tiny West Virginia fire department because they didn't get a signature for the transporting of the Medicare patient. Wasn't that the patient needed to go? They just failed to get a signature patient, and they had to pay back $33,000, and then they had to go under a corporate integrity agreement for $33,000. We used to say, because I remember going around consulting and say, if you're smaller than 50,000, don't even worry about it. You're going to be like, they're focusing on the big dogs. That is not happening. What we're seeing is what's going on with OIG right now. And there is an initiative because Trump wants to save $1 billion a year. So they're going to try to figure that out. So then we're going to get all of a sudden they start targeting EMS. Then you're going to see a lot of this advocates. They really do want to come after volunteer government providers. So then you know how people are, like thinking, well, they should have done this. So we got to start figuring out, are there policies that we need to get passed or done by this administration before that happens? One of them is restricted PCS. One of them is making sure our technologies understand the electronic signatures. You know what I'm saying? We're still doing paper shit from 1980s. You know what I'm saying? You should be doing that. We're in the 21st century. Why are we still signing contracts? You know, I mean, for God's sake, I bought a house in California last week and they had to send somebody out, so I had to sign all this. I'm like, paper. I have a stack of paper in an environment where I do all my contracts through DocuSign. It's all HIPAA compliant, it's everything is there, and we're still doing the same thing that we're doing. This administration under these corporate CEOs that are running these large systems understand that dynamic. And so they're going to bring us as a healthcare industry, basically modernize this pretty quickly. Gotta love it. Here's your advocacy piece of it. Remember, people will feel before they think. How can you use that for you? Remember, who are you advocating to? You know what I'm saying? Who are you advocating to? Who are you going? I was telling this to the Texas providers 2 days ago about the same thing. When you're trying to get an initiative done, you need to understand, how do I make this a win for everyone? Not a win for you. So you can go around and tell everybody, look, you did. Dallas, I already did. It's wonderful. You need it to be to where, how will the governor say, I protected many of my citizens in these rural areas? All the people that come to Vail to go, or Aspen, or wherever else that they go to Snowski or whatever. I'm protecting people that are coming through. You need to make them feel like they're the hero, not yourself. And anytime we get out of that mindset and we start doing it, it's really amazing what starts to happen. So I'll stop here because I think we're down to 5 minutes or whatever. But any questions, guys? I'm going to leave it here. If you've not, whatever, I'm doing another shameless plug for my leadership lab. But this is the one thing that I did learn from Donald Trump in 47. He won the election. Many people did not see it happening because of the podcasters. Okay. And the one thing about the podcasters is they got the information to the people. Okay. Too many times people control it, and it happens in the healthcare industry. Many times we're allowing the narrative to be controlled. Some of it is just not factual. And so we've got to talk about it. It can't just be coming from people like me. It has to be. So you're going to see me introducing people. I've got somebody coming in on October the 22nd. That is a doctor at Johns Hopkins. Very, 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 very smart. He's probably going to say stuff that we don't like, but we need to hear. He has an ear in this administration. Goes to a lot of committees, congressional committees, but there's a lot of things that he actually agrees with. And one is, if you do your facility and you do that physician certification statement, the doctors do not understand why, if they prescribe something, that it doesn't happen. And that a paramedic can tell them, so sorry, this doesn't need that. They don't understand it. Now, what I would like somebody like that advocating a position to say, if you ordered it, you get it. If the doctor's misordering it, they're bound by a oath that we're not technically bound by. This is what's going on with pharmacy, all of that other stuff. They're in uproar. I mean, there was an uproar with some pharmacists, some doctors ordering a certain thing, and some pharmacists didn't like what they had ordered, and it made a big hoopla, and they were fined. CVS was fined. So why are we allowing the same thing not to happen with us? And so these are the type of things you tell your story, but we can tell whatever. I've been telling that story since 2012. Still haven't been able to. So start telling us some different way. Does that make sense? So these are the different ways to start thinking. If things aren't happening in your initiative, start rethinking. Am I telling the story correctly? How do I do that? Go to YouTube, type in Story Brand. It's been around for a while. I had aha moments when I brought a marketing firm in to help our firm, and we're moving into different spaces, and it's been amazing. I've had more growth this year than we've ever had in our entire life. But it was, and I think it'd be God. Story Brand works. Because I've been trying to get through it. And we don't like to say that I'm not doing it, but yeah, when you start going back and they really take you through the dive, take you through and start reading what your website says, and let me see your communication. You're like thinking, oh, what did we do wrong? What have we done wrong here? And I saw that in the advocacy piece as well. Many times we're trying to position ourselves. We can save the healthcare industry, Senator Cassidy. What do you want? He wants to know, how can you make him look better because he's in a contentious election that's going to give him what he needs. And if I can solve that problem, then he'll bite on whatever we bring. That makes sense. Same thing you're going to do with the rural health transformation person. So I'll stop here. Any questions? We're at the 1 minute. All right, guys.
Before you leave, Bill, Cheryl was, was texting, or Cheryl was texting with me. That it's kind of scary that we don't know who's, we don't really know who's leading the effort in Colorado, and I think she's got a point. To get in to be at the table. I told her, well, Tim and Sean and Austin, they're working through MSAC, but do we have that happening?
I thought it was James till he said he wasn't.
I'm with you, I thought it
but
was
I-
James also, so
But
I think
I
that's
do
where.
know that TDPHE is in the conversation, so Bateman is probably our guy to talk to, because it's been agency to agency thing. HICPUF to CDPHE, so.
And I think what you just described is what Cheryl is concerned,
Yeah.
we don't know who it is.
Yeah, because the last thing we want is the health department representing EMS finances, because the first thing they'll tell you is they don't do that.
Tim,
So Ken, the first problem was we didn't know who to contact, who to go to get a seat at the table. We now have that information, we now have the seat, and now we're working on that coordinated part of who's gonna be that person. And what is the message going to be? Because my guess is you're speaking about the rural transformation funding project?
Yeah.
Yeah, we're actively working on that, working on the plan, working with the person to get that done.
Who is we, Tim?
Pardon me?
Who is we?
So it's that MIH committee. Remember, we broke up into two groups,
Names, Tim, names.
the central service and the kind of the TIP committee. So we're working on it.
this is through the advocacy committee, yeah. Cheryl, you had your hand up?
Well, yeah, I think that I had a conversation with Martin Duffy about this a couple weeks ago, and like, it does feel like it's a little bit of a runaround because, they're like, well, we're aware that this is happening and here's what's happening and the timeline is short but again, like you guys are talking about the names of like, who's at the table and what are we doing about this? Because we're waiting too long, almost like, because their window is so short, but I appreciate Tim's effort. I think, as long as somebody is getting there and we know who that is, I think we have a better chance at making a change.
Thank you, Cheryl. Kelly?
I think a huge opportunity
Can
for
you kind of stand and speak to the deal a little bit better?
huge opportunity for EMS is to partner with the Colorado Hospital Association. I know I said hospital, I'm sorry. To partner with like Tom Rennell and those players, because every other week we're meeting with HICPUF and Kim Finster to talk about the application process for the hospital transformation program. I sit at the table and I yell about ambulance districts all the time, so I am yelling for you. And it'd be really nice to see more voices partner with CIJ, because we are the ones trying to drive the application. I'm gonna tell you right now, HICPUF does not like any medical services. I mean, they've been trying to dismantle every hospital in the state for the last 5 years. And so if we can have more representatives attending those calls, then HICPUF will see the voices, and the strategic partnership, which is exactly what the OBBB is encouraging, right? It's that strategic alliance it's just supposed to have in rural communities. So if anybody wants the Colorado Hospital Association links for those HICPUF meetings, let me know, and I can get you that information.
Basil, anything else?
Fantastic. And she got something there, like whatever that new there is, y'all need to just have a unified voice, and what's the plan? So when you don't have a plan, people will start making up their own narratives. And so that's all I'm saying, because this is moving very fast, and y'all need to push the information out on what you're doing to your states. Or you're gonna have several people talking to different people. So when people are calling in, I'm like, y'all get together quickly, figure out who it is, because what happens is you're gonna get 20 people gonna be annoyed and you're not gonna get any. It sounds like you need to be the person that's the voice in my opinion, but because you're already at